just saying. So if you're joining us online, or as a friendly reminder for those still with us, you can type your questions in the Q&A box. So if you've been following Quality of Care NL this year, you'll be familiar with the new webinar series we've launched called Healthy Discussions, where we had quality conversations about health and social care in Newfoundland Labrador. Inspired by the webinar series, our next Healthy Discussions with Healthcare Leadership. I'm delighted to be joined today by several key leaders in our healthcare from the provincial government and NL Health Services. Dr. Patrick Harvey, Deputy Minister of Health Transformation with the Government of NL. Joining us from NL Health Services, Kelly O'Brien, Vice President of Quality and Learning Health Systems. Cassie Chisholm, Vice President of Transformation Health Systems. Darla King, Vice President of Transformation Wellbeing. And T. Evans, Senior Director of Provincial Health Transformation. I want to thank you all for joining us today. As we do for our Healthy Discussions webinar, I'm going to kickstart the discussion with some questions for our panelists, and we will save some time for the audience to ask the questions. So I'm going to kick things off for everyone. There's a three-part question. I want you to quickly introduce yourself. Now, this is in 1 to 2 minutes if you can. Introduce yourself, what your role is with NL Health Services or the provincial government, and name some main priorities which you're going to focus on over the next year. We'll start with you, Kelly.
Well, Robert, I have pages I wanted to speak to, and I only have 2 minutes. Anyways, thanks very much, Robert. My name is Robert said is Kelly O'Brien. I am with Newfoundland Labrador Health Services. I've been with healthcare in Newfoundland for a long time, but I just recently had a couple-year break working in Ontario, where I've seen many similarities in terms of strengths and opportunities. I trained as a physiotherapist, and I'm really delighted to have the position to serve as a position of quality and learning health systems with the new health NLHS. So my role basically is really about trying to create that culture that enables continuous quality improvement within the health system, and also to bridge the partnerships to create that learning health system, because learning health and social system, because we can't do that alone. So a couple of my main priorities, certainly since starting in July, have been really around continuing to support quality and safe care as we integrate and transform the system. So continuing to make sure that we deliver exceptional care processes and standards, while leading and supporting the development of a new foundational work within the health authority. So things like the strategic plan, which we just launched, our new vision, mission, and values. That was some of the work that we've been focused on in the last 6 months. Some of the other work that we've been focused on certainly has been around leaning into the strengths of the legacy organizations, because there are lots of strengths within the legacy organizations, and really trying to create integrated quality structures. So what do the team structure look like? What do the processes look like? And what are some of the capacities that we need within the system, within the people who work within the system? So we've really been working on our patient engagement strategy. We know we can't do anything without the patient voice and being engaged in our work, as well as focusing on the accreditation process at a system-wide level. So really looking at those national standards and how we're meeting them. And we've also been focused on really working with digital health around access to data and information. So this is an area we're really excited about as a single health authority, as we move to an integrated health information system, and really leveraging the possibility of that to create data that clinicians can use at that point of care for ongoing improvement. So this is really important in health and social system. So our work really has been about setting that stage for the learning health and social. And I'll stop there. That's 2 minutes.
Thank you. Tina?
Thanks, Robert. Hi, everyone. I'm Tina Evans. I'm the Senior Director of Provincial Health Transformation. And I guess part of my work right now is around our strategic health networks, which another question a little later may probably address, but establishment of those strategic health networks across the province, so we can bring together zone leadership with partners both inside and outside health to really look at innovative solutions to complex healthcare challenges. The first 4 networks have been identified. They're primary health care with early focus on family care teams, surgical services, emergency department, and health of older adults. So my focus right now is really getting the leadership in place to enable those networks to be in place so we can move forward transformation on a provincial scale.
Pat?
There was a minute. I have your extra minute. I was leader of the quality of care program until a few years ago, and its work kind of influenced the creation of the health accord. And then I was co-chair of the health accord with Sister Elizabeth Davis. And to summarize that, we wanted to increase awareness and implement improvement in the social determinants of health. And we wanted to reimagine a healthcare system that had more continuity between the acute care sector, the long-term care sector, and the community. So as a consequence of submitting that report, I was asked to be the Deputy Minister of Health Transformation to try and influence its implementation. And with that, Heather Hanrahan and Lynn Taylor came over with that team, and to which has been added Antoinette Cabot. So our job really is to try and ensure that the spirit of the accord and the actions of the health accord are implemented. So on the social side, what we've achieved, I think, is we had this week of wellbeing that was all about awareness, but it was also a kickstart into creating the ground for interventions that would help in the social determinants of health. And you probably saw the announcement 2 days ago on poverty reduction, and that was very consistent with what we wanted, and we influenced it quite substantially. And that was an $85 million investment. So the other areas that we are focusing on for the next year are going to be improvement in poverty reduction still, and the focus on seniors and what we should do there. The idea that education is a social determinant of health, and early childhood development is an area that we can improve, and upskilling youth, people between 15 and 30, so that they can get jobs, is the next area of a big concern for us. And then the third area is that of health promotion, so that we can actually influence the population to have healthier living objectives. And then the last one is, which is the most difficult one, is to try and influence the reality in this province that there are groups that are excluded whose health outcomes are worse. And they would be Indigenous people, Indigenous nations, LGBT community, disabled, and immigrants. And this, for me, that's really difficult because I know nothing about it. So being able to influence that is going to be an important objective. And then on the healthcare side, there's been very substantial change. There's been the structures have changed. You've heard of these people being announced all with health transformation titles. That's highly innovative. And then there are other things happening that are highly innovative, that are whereby we're doing a lot of things at the same time to be able to move acute care to the community care. And I would include in that family care teams, the emergency services, trying to get an integrated air-ground ambulance system still in progress and an objective of government. Urgent care, a good urgent care capacity, good virtual care capacity, being really important. And then has been mentioned that the health information system has been a policy of government, they've got a vendor and they're having a contract, and that health information system will be transformative in integrating not only healthcare, but the social side. So that's important, obviously important to us. And then in the community and the hospital side, seniors care requires revolution. And you heard the announcement last Monday about centres of excellence in Corner Brook and in St. John's as being starting and transitioning the new St. Clair's to a place which has got geriatrics as a focus of the hospital, with acute care of the elderly units, restorative care, rehabilitation, age-friendly emergency rooms. So that is a priority of government, and it's a priority of the NL Health Services as well. So that's not innovative. That's us catching up. But there are a few other things that we're doing that are really innovative. The Cardiovascular and Stroke Institute, with an emphasis on prevention of these events. The child health model is going to be innovative. We haven't fully finished with that. I think that the other pieces that we need to mention is maybe we might be the first province that has made a made a primary objective is to create a learning health and social system in the province. Lots of hospitals are more further ahead than we are, but the idea that the whole province will get into a culture that depends on trying to match actual practice with best practice for the use of metrics that relate to practice is innovative, I believe. It's a challenge, but it's innovative. So I think we got a lot of stuff to do in the next year. And I hope I'm still around to do it.
Thanks, Pat. You really took Tina's minute there.
Yeah, 100%. And they be part of mine too, bro.
Was I too long?
All good, all good. Good morning, everyone. My name is Darla King. I'm the Vice President Transformation Wellbeing, as Robert has introduced. So I come from my legacy organization is Western Health, where I worked for about 30 years in various capacities, most of which were in the community sector. So that's part of what I bring to this role. So I guess as a part of the new Newfoundland Labrador Health Services executive team, we really all have a part of that role in transformation that Pat has described there as called for in Health Accord. Of course, each member of the team has their own sort of specialty areas that they're focusing on. And mine and Cassie's are transformation. We're part of that innovation that I'm happy to hear that Pat thinks that's innovative. So that's part of our work. Sometimes we call ourselves the transformers just to be kind of cool, but anyway, so basically, what we're trying to do is our lens is to look at those calls for action that were identified in the Health Accord and really have a lens on those big picture transformations. So, working with Kelly around the transformation around the learning health and social systems, integrating with all of the members of the team, but really having that kind of big picture around provincial outlooks and really transforming and being innovative. I guess some of the things that are priorities for me at this point, one is I also hold a responsibility for provincial program. So up until now, we've had individual sort of public health units in different RHAs, and now we're coming together as a part of a provincial program. And I think that's a unique opportunity because, of course, we are trying to focus so much more on those social determinants of health and the well-being side, and public health has a lot to offer that from a leadership perspective. We've just recently had a new provincial framework for public health released by the department, and we do really need to rebuild and regrow and have that team be able to support those focuses. Areas around action on the social determinants of health and well-being. Other significant areas of my portfolio would be Indigenous health. So another area where we do need significant transformation, and we need to be able to partner effectively and have meaningful interactions with our Indigenous governments, partners, and communities. And that is something that's really important to us as an organization as well. Another piece that we've worked closely around is the family care team model. Again, this innovative approach for primary healthcare delivery. We've started already implementing family care teams throughout the province, but we really do need to look at the model of care, making sure that people are working to their maximum scope of practice, really engaging with the community sector to look at, population health within communities, not only the health services that are being delivered. So those are some of the key things that are important to me.
Thanks, Darla. Cassie? The other transformer?
I think. My name is Cassie Chisholm. I'm Vice President Transformation Health Systems with Newfoundland Labrador Health Services. And like Darla, I also have responsibility for several provincial programs, one of which is the cardiovascular and stroke program. Another one is clinical efficiency and the provincial paramedicine and emergency transport. Darla and I together, and Tina, are working with the strategic health networks that we're looking to stand up, and those are extremely innovative in our space. There are certainly places in Canada and elsewhere in the world that have started with strategic health networks, but they're new for us here, and we're forging our way forward. Some of the areas where I have priority work happening, particularly with strategic health networks right now, is in surgery. I'm sure folks would have seen lots in the media about the backlog of joint replacements we have and some of the access issues we have around particular surgical categories. So I'm spending a lot of time in that area right now, as well as access to emergency care. Within the cardiovascular and stroke program, there's a lot of important work happening right now. Cardiovascular disease, including stroke, exerts a huge burden on our population, and I'm really, really excited to be in a position right now where We have our provincial health authority, NL Health Services, and our government and many other partners in the landscape lined up and pointed at being very strategic about prevention and management of cardiovascular disease. And one of the ways that we're getting at that is by taking vascular disease, cardiac disease, and stroke and housing them in one provincial program. So we feel that this is extremely innovative. There's really nowhere else in the country that's doing this right now. And very few examples in North America, to be honest with you. But it certainly seems to make a lot of sense from a logics perspective. There's a shared pathogenesis between those three conditions. And if you look at it that way, there's also a lot of shared opportunity for prevention and management of the conditions. So that's where I'm spending a lot of my time, and I'm sure we'll get into more detail as we move through the presentation.
Perfect. So Kelly, I'm going to start with you. I got a two-part question. Can you elaborate on the concept of a learning health system? What are the...
Thanks, Robert. So I think Pat actually spoke to this quite nicely. It really is where that internal data that's generated at the through care processes, and also through patient experience, are systematically integrated with external evidence, and that knowledge then is applied into practice. And we know we have certainly have some gaps, and what, as a result of this, what happens is that we deliver higher quality care, safer care, and actually the healthcare delivery system becomes a place where workforce can excel. So if I were to think about the pillars, I really think at the heart of a learning health and social system are the people. That's what comes to my mind, first of all. It's really about engagement of patients, it's engagement of providers, researchers, industry, in identifying problems and solutions, in ensuring expertise-driven practice, working as a team. And it's key that at all levels, there are competencies around a learning health and social system. So competency around data, competency around rapid improvement. It's really essential to form communities. And so when I think about the strategic health networks, they're actually learning communities is what we're creating as a structure at a very tangible level within the organization and across the province. So those are examples of the people side of a learning health and social system. It also requires system leadership. Definitely a collective leadership where everyone assumes a responsibility for quality. So it's not just one individual and continuous learning. It's the success of the organization actually depends upon that. Leaders who are actually formal leaders instill that culture of collaboration and adaptability to support the learning process.
Thank you, Sari, for agreeing with me. Thank you.
We'll actually close our session for this.
That's okay. Thank you. I love that. Another pillar that I think of when I think about the learning health and social system is really about access to electronic data, health data, and data analytics. They're central and core to the learning health and social system. So we really need to be able to harness the power of that data from multiple sources. So patients, research, and feed that knowledge back into information and decision making and continually evaluate. Access to research is also really important in the learning health and social system. And really it's about how do we translate that into, analyze that into usable information. So building that analytic capacity in the system is really important through partnerships that produce and share research as a way of synthesizing existing research. Another pillar for the learning health and social system is really an organizational infrastructure. So we need to have governance models. And so when I think about the transformation framework, the quality framework, these are all really about governance models for us that embed rapid learning and improvement into practice. So I already spoke about the networks where problems are identified. We do have some gaps and we know that, and that's the work that we're doing. We're working to build up, we have lots of assets. And so we're working to build up those assets together collectively across the system. And as Pat indicated for us, it's also about a learning social system, which is innovative in the province and probably innovative. I haven't seen it anywhere in the literature. So we really are looking at how the learning health system is a bridge between quality health system delivery, but also the social determinants of health. Another pillar would be that culture of learning and innovation and quality improvement is science, implementation science. All those pieces are extremely important in a learning health and social system. We often have really great ideas in healthcare, great solutions, often generated from the front line, and have significant challenges with implementation. So we know we need to look at the barriers to implementation and do better in that space. So we're going to focus on that, certainly. Partnerships and collaboration are essential as well. It's just a couple. That is. Sorry, would you like some more?
Just as a follow-up, what does it look like in practice and how does it benefit the community as users of the healthcare system and of course the social system?
Thank you. I think when I think about it in practice, COVID-19 comes to mind for me. It really demanded immediate response from the health system and around the world, and us included. And so we adapted very rapidly and continuously, putting new evidence into practice very, very quickly. So that really and transforming the way we delivered care. So that really is a great example from my perspective. And I know my colleagues are going to speak about some of their examples, so I'm not going to go into that. So, in practice, it's about putting people and learning at the center, as I said. It's about that connection between researchers, providers, patients, and communities, embedding research from start to finish into practice. So, what was your second part of your question?
Just how it looks, how it would benefit the users.
Thank you. Really, it's about being a high-performing health system. And so it really is about achieving that quintuple aim. So all of us want to have health care, which is high quality, so that we have great outcomes, we have an exceptional experience. We also know that we want to have better value. So we want to have those outcomes and experiences at a lower cost. We have to address the health equity, as Pat spoke to. We must do that. And we also want to improve population health. So that's really what it looks like in practice, is that we will transform the system to achieve those outcomes.
Right. You mentioned involving the patients is a good segue from this morning's session. So we move on to Tina here now. Tina, strategic health networks currently being developed within Newfoundland Labrador Health Services. The aim of supporting an integrated, unified approach that creates consistency and standardization across zones regarding quality measures and standards of care. Can you tell us what a strategic health network is and how they contribute to a learning health and social system?
Sure. So Kelly gave me a good segue into the strategic health network discussion. And I guess before I describe what they are, I'll talk about the structure in terms of Newfoundland Labrador Health Services, because I guess that really describes why we need them in place. So within Newfoundland Labrador Health Services now, we have services that are either delivered through provincial programs, as Cassie and Darla just described, which are responsible to a single vice president, or we have services that are delivered through zone-based operations and responsible to and accountable to a chief operating officer within one of 5 distinct zones. And because of the way provincial programs are set up with their responsibility for operations, staffing, budget, quality, I'll file to a single VP, then, standardization on a provincial level is really enabled through that structure. But programs like mental health and addiction, surgical services, emergency, primary health care, for example, fall to that accountability in a zone. That's really important, though, because it allows for that local context and local decision-making at that level. But because of that, you can get inconsistencies across programs. So that's where strategic health networks come in, is that transfer mechanism that brings zones together on a provincial level to look at quality and standards of care. So that's basically why strategic health networks, I guess, were really needed in this new structure. So strategic health networks bring together groups of stakeholders inside and external to health, along with patient partners. We recognize their voice is really important. We want to have that at the beginning in our planning discussions to really look at innovative solutions to complex healthcare challenges and look at best practice, evidence, innovation, and really how we can deliver that on a consistent level provincially. We have a core team that's going to support our strategic health networks. That'll include evaluation specialists in knowledge translation, so getting that evidence to practice environments where really the change is going to happen to improve health outcomes, and quality expertise and quality improvement. And together then with our partners in the research and innovation space, we'll really look to those best practices and try to implement them on the ground in the zones and on a consistent level to really reduce unwanted variation and improve health outcomes. So for me, the strategic health networks really optimize that environment for a learning health and social system, taking best practice and translating it to it's on the ground.
Right. It's almost the foundation in a sense, yeah.
Yeah, absolutely.
Thanks, Tina. So Pat,
Oops.
moving on to you. In September, the provincial government launched the first Wellbeing Week in Newfoundland Labrador. Can you tell us what the term well-being means and describe the provincial government's approach to well-being in the context of health transformation?
Right. I think there are kind of three nuances that I'd like to put across here in answering the first half of the question, and I'll deal with the kind of structural part of the question subsequently. So the kind of nuances are that we tend to think of our well-being as physical, right? It's you're walking and your blood pressure, and your blood sugar, and your blood this and your blood that. But there are other important components to it as well, particularly mental well-being, social well-being, financial well-being, and environmental well-being, and that the quality of our lives demand that we have quality in all those environments. So that's one nuance. The second nuance is that we tend to equate our health with the healthcare system. But the reality is that our health outcomes are driven more so by social factors, education, justice, environment, etc. So again, we need to broaden our focus. And you realize if we've broadened our focus, if the way we spend our money. So we spend our money to a dominant extent. There's probably 4 times as much money spent on healthcare than there is on the social terms of health. And the public discourse has been about family doctors and not about the social determinants of health. And the third nuance is that if we're serious about these social determinants of health, it's not the government's responsibility. They will develop policies and put funding into particular areas that they influence. But the reality is that how we and our families and how we live in our communities function. And that the communities and municipalities, etc., have as much an influence on well-being, or more of an influence on the well-being of us as individuals and families than the provincial government has. So that's a kind of a broader approach to well-being than we traditionally have. And obviously that's creating awareness around that is paramount, because you want the people to vote in favor of action on the social terms of health, right? And if they're not aware that it's important, then they may not vote for it. So that's the kind of our first bit of logic. And then the second bit of logic is around what structures can we develop to change the social determinants of health in this province. So you know as well as I do that the provincial government runs in departments and it's siloed, and the health authority probably is pretty solid as well, right? In that it's got a cardiac program and a mental health program and this program and that program. And the social side of it is totally fragmented. So what we're suggesting in government is that there would be a well-being NL structure that integrates the departments across and deals with those issues that require integration. And in particular, I think the example of social well-being will be one that every department influences, and what their decisions are influences those. So that well-being NL has been created with deputy ministers in various departments and external people who have got expertise to be able to help that. And we're creating a deputy ministers integrated committee who feed into a ministerial committee who are then meant to act on behalf of this integrated approach in cabinet and in the public arena. And you can see the Premier is speaking that language, right? I think that he spoke that language in the poverty reduction piece yesterday. So that's the central piece. So getting change there is one thing. Then what about where the people are? And the people are in the regions, and the regions have different social problems. And we're recommending that an approach there would be around regional well-being networks and regional well-being teams that would try and identify these problems in their arena the solutions to it, and a bidirectional connection with the provincial government or the central government to try and get solutions that match what's happening in their arena. And we also want to be, so these networks then would be a table for the principals in that region who are responsible for health and the social system and the schools and the justice system and community sector and the indigenous people, etc. Those tables would discuss their local region, and they'd be informed with data that arises from the voluminous administrative databases and the census and the various surveys that are done that are pertinent to their region. So that's our kind of structure that we are going to roll out. We're going to roll out one in Western because they're the furthest ahead. And we're going to roll out one in Labrador because they got the biggest problems. And then we'll roll out the other ones then subsequently. So that, and then there's a third arena to this, and that is this lady's job, right? Which is that the provincial health authority is a massive employer of people that's present in every part of the province and has a direct responsibility for public health. And within that piece, there is a health promotion and prevention component, but there's also the idea that the social determinants of health need to be impacted upon and improved. And they themselves have structures within the community that allows them to get information about what's going on in the region. So we see this approach as being tri-directional, that there needs to be a central alignment, there needs to be a regional alignment, both with the health services, NL Health Services, and with Wellbeing NL. So that's a rather long-winded approach to what structures we're trying to develop.
Darrell, I'm going to move on to you. I got a two-part question for you. What does the term health equity mean? How are we working towards delivering equitable healthcare for everyone in the province?
Okay, well, thanks, Robert. So health equity, I guess, just simply put, is a state where everyone has the same opportunity to lead a long and healthy life. By everyone, we would mean regardless of where you live, how much money you make, what your gender is, what your race is, what religion you belong to, et cetera, whether you're disabled, all of those factors. And, in reality, as Pat has just alluded to, we know that all of those things, impact your health to a significant degree. If we look even at a macro level at what the Health Accord told us, it told us that if you live in Newfoundland and Labrador, there's health disparities when we compare our health with that of other provinces, right? We have the highest rates of chronic disease. Our life expectancy is shorter by virtue of the circumstances that come along with being a Newfoundlander and Labradorian, which is, of course, what is prompting us to look at things differently and try to be transformative. So the second part of the question, I think, Robert, was around how are we at Newfoundland Labrador Health Services going to aim towards equitable health services delivery? And I think first I kind of want to pick that question apart a little bit because it kind of implies that we want to do things the same everywhere, and how can we ensure that we do that? And that is actually not what we want. We don't want to have things delivered the same in every region because we know that each zone and region, there are different health disparities and different needs. So it's not about trying to develop a system that will do everything the same. It's really about trying to figure out what the needs of people are, why there are health inequities, and what we need to do differently so that we can have health equity. So I think, what we're really trying to do is at Newfoundland Labrador Health Services is try to figure out what do we need to do differently so that we can aim to have health equity at a population level. And I'll speak maybe to three different strategies, I guess, or approaches. The first would be really, building a strong foundation for health equity. So we really, we're a new organization. We're just we're building our organizational structure. We're developing our mission, vision, and values. We really need to make sure that health equity is in the forefront in all of those conversations. So, one is hiring a VP of transformation and well-being is a part of my responsibility to ensure that happens. We look at our new mission or our new vision statement. It's health and well-being, every person, every community. So every person, again, not depending on where you live or depending on your level of health or your socioeconomic status. So we are really trying to embed those things. Kelly in her Leads for Quality has a quality framework that we're looking at quintuple aim. So health equity is a part of that structure that we're building. So, as we're building our strategic plan, as our managers and directors are building programs and policies, we will be embedding those types of ideas there so that we will make sure that this is in the forefront of us as we go forward. The second thing, I guess, that I'll speak about is really using evidence. So, we're talking about a learning health and social system. We're talking about wanting to have evidence and understand it and then use that to drive improvement. So when we talk about health equities, one of the first things we need to do is actually be able to identify where they are. And right now, we don't have a good ability to really we don't have good access to that disaggregated data. So we can look at what is our data about these, different ways of stratifying things. So looking at, your place of residence or your occupation or how much money you make or whether you're Indigenous or not and what that means for your health outcomes. So we really need to build that into our system. We are looking at a new health information system within Newfoundland Labrador Health Services. And that's one of the pieces that we are making sure that we build that ability to pull information from our system about our clients so we can better understand and identify where those health disparities are, so that we can then do things differently and actually put strategies in place to help close those gaps between the health disparities. So that is certainly a significant piece. And, the learning health and social system that Kelly has talked about will be a prime way for us to do that. Generate new information, understand what it's telling us, and then figure out what strategies we need to do in order to really be able to close some of those gaps. And of course, that data will also be able to help us measure whether or not those strategies that we put in place are actually working. So there's probably lots of research opportunities there and abilities to partner. We've already been partnering with Quality of Care NL and with MUN in lots of ways around research opportunities, around knowledge translation to help us get this information out even as we're developing it. The third thing, I guess, is when we talk about, how we're going to sort of tackle health inequities is really, I know we're talking about Newfoundland Labrador Health Services role here and what we're going to do, but really we can't do this alone. Like, this is not something that we as one entity can do on our own. And, Pat has talked about that in terms of, in particular, around a well-being agenda. Nothing about us without us, right? So if we're talking about trying to close gaps in Indigenous health, we need to have Indigenous partners at the table. They know their communities, they know what their issues are, they know what the solutions are. So we need to be co-designing these things. So part of what we're doing now is really trying to build those relationships to be a part of some of these structures that are happening across government with other agencies to really make sure that, that we can engage with others that can help us find out these solutions, right? I'm so glad that the Health Accord is a 10-year strategy, because it's going to take us longer than 10 years to tackle some of these problems, but it is, definitely worth doing. I think I'll.
Thanks. And like you mentioned, it's not going to be one that covers the entire system. It has to be different between the zones that
Absolutely
populations. And I think the system also has to be adaptable and flexible. And I think a learning health and social system will help with that. Thanks, Charles. So I'll move on to Cassie. Cassie, can you tell us more about the digital transformation happening in healthcare, and specifically around virtual care, the health information system, and clinical efficiency?
Thanks, Robert. So in terms of digital transformation, I guess I'd step back from it and just healthcare in general, like what part of healthcare these days isn't digital? It's really starting to permeate everything we do, every tool you put your hand to. There's almost nothing stethoscopes these days, oftentimes what you see around a physician's neck or a nurse practitioner, they're digital. So those tools have become so ubiquitous. But at the same time, when you look at just take Newfoundland and Labrador Health Services as an example, we're certainly not unique in this. There's many jurisdictions that are undergoing transformation in the digital sense. We have major components of our, I'll say, digital infrastructure, our electronic infrastructure, that have been around since the 80s and need to be updated and or put in place in the first place. And the obvious one, of course, is the new health information system. And, it strikes me often that we use that word health information system, or HIS, often, and there's probably lots of people who don't truly understand what that means. I'm going to take a chance that there might be a few in the audience right now and just let you know that what we're talking about when we say health information system is that piece of software that manages just about everything about your health record when you enter the healthcare system. Now, that's a very crude way of looking at it because there are certainly components to an electronic health record that sit in the community and some that are more suited for cancer care and some that are more suited for emergency care, cardiovascular. But in today's world, you know, the trends in digital health are for all these systems to be interoperable, which means that they can talk to each other. And right now, in our world and in many jurisdictions, what the situation is that you have component pieces of digital infrastructure that don't talk. And so patients often think, well, why am I telling my story 50 times? Why am I telling you again? Don't you know that? And it strikes me and many people as completely mad that, you know, I was in emergency last week. I had this problem. I'm back again. How can you not know? But the truth of the matter is we're not connected to the extent that we can be or should be in that way yet. We're going to see a lot of that change with our new health information system, which is going to come in the next 1 to 2 years. But we're not waiting. We've never, ever intended to wait. There are many pieces of our digital infrastructure that have already been refreshed. And we've got a bunch of examples here in our environment where we built our own and we built them well. You know, we've got examples here that are kind of leading the pack in the country. And one of the ones actually is quite close to the work that I do, even though I can't really take any credit for its original design, is something called MyCCath, which is a piece of software that we use. And I use it as an example because you asked me about how do digital tools transform healthcare. Well, aside from the fact that they take things on paper and move them into a digital format. So all of a sudden, you know, they're more accessible. You can pull the data back out of it. You don't have to worry about storing paper. Like the NL Health Services and the former health authorities spend more than I'd like to talk about on storing paper, you know, from years and years ago when things were only in paper. So those are some of the obvious advantages. But there are some that are much less obvious. And I draw your attention to things like what we call clinical decision support triggers or tools. So for example, if a patient comes in with a set of symptoms and those symptoms are input into a digital tool or a piece of software, the modern pieces of software that are built well, like the MyCCath platform that we built here, are smart. They have logic built into them that starts to guide the provider towards the best and most appropriate test or the next most appropriate test for that patient. And I don't want to make you think that our providers don't know these things, but if you look at the aviation industry, we don't leave it to the pilots to know everything, right? We build redundancies into the system when we build opportunity into the system for the system to also have a role in guiding the transactional things that happen. So I could probably go on and on about this for days, but I guess suffice to say, you know, digital transformation is a huge underpinning of the transformation that we're trying to achieve here. I think you asked me specifically, Robert, about clinical efficiency. I think it won't be unfamiliar to anyone in our audience that bed flow and access to beds, and particularly inpatient beds, just as one example, is a huge topic. You know, when we hear about our emergency rooms backed up or do I have a bed, this is all about bed flow and whether or not we have that access available in our acute care facilities. And we have a system that we're putting in place here right now, a digital system called ICM, or Integrated Capacity Management, which is designed purposefully to give us visibility at 100,000 feet, so to speak, to all the beds and all the capacity across our system. And you can imagine that's complicated and it's not done overnight, but we've moved quite deeply into that process. And now, when we look at the system from that sort of higher vantage point, we have the opportunity through the ICM tools to say something like, okay, we have 3 patients here in the Eastern region that their home regional health authority or their home region is Western. But Western's capacity today is next to none. Eastern has a little bit more. Okay, today is not the day to repatriate those patients across the province. It sounds rather simple, but a couple of months ago, we honestly didn't have that visibility on a dashboard, and all that information required phone calls. And you know what it's like trying to manage things like that by way of a phone call. So it's one small example of how digital tools can help us with clinical efficiency. I think I'll stop there, but ask me more.
Lovely. I'm mindful of time right now because I want to get some interaction from the crowd. So I'm going to ask everyone to kind of conclude, give some concluding remarks on basically where you see the future of health transformation in the province. I'll start with Cassie.
Want me to start where you left off? I can think just in conclusion, what I would say is this is an exciting time and a time, you know, from my own perspective, and I think a lot of people would share this, that the stars and the moon have aligned in a beautiful way for us to actually make changes that many of us, and I suspect if you're here, you're one of those people that have wanted to see for a long, long time. And it's a great place to be right now. There's so much optimism and energy and growth in our system in a very positive direction. And there's nowhere else I'd rather be right at this moment than doing this work.
Yeah, no, I agree. I think, lots of optimism. And, you know, one of the things that excites me the most, I think, is the work around well-being and the social determinants of health. I think we are the envy, to be honest, of many provinces. I was recently at a national public health meeting that focused around some of this work, and we were the envy of the room as I heard colleagues from across the country talking about if only we could, and if only we had influence on policy and we had connections in these places. And I said, well, we do. Right. It was actually ironic that the week I was there was when we were announcing the week of well-being here in the province. But, you know, to have like a document like the Health Accord that so clearly lays out for us the path that we need to take, it actually has a blueprint that really identifies the underpinnings of what we need to do, and has really identified that, you know, the focus on the social determinants of health as equally or more important than the health system, I think has led us on a beautiful path. And, you know, I think we're going to see improvements in health outcomes because of that work. So I'll pass it over to Pat.
Good to see everybody so optimistic. I think that it's gratifying, obviously, to see the Health Accord still being at the forefront of the NL Health Services, and at the forefront of Health and Community Services, and at the forefront of the Premier's mind, and that this plan is accepted, etc. But I worry a little bit about, I don't worry that did we get it right, actually. I think we did, because everybody agrees with us. And pretty outside of the province, they kind of agree with us. But I worry about whether we can implement, and whether, if you take the social determinants of health piece of it, whether it's feasible to get upstream interventions to get downstream benefits when you don't see those benefits for 10 or 20 years. And the political pressure is to get more family doctors today, take them off a tree and hang them in some place. Right? Whereas the reality is, of course, is that action on the social determinants of health is more important. So that whole piece about awareness is really, really, really important. So that piece kind of, yeah, and I don't worry whether we got the components of the actions that we want to do about poverty and health promotion and education and inclusion. I don't worry about that at all, but I do worry about implementing those interventions. And then when it comes to the healthcare system, these people are swamped. Like, the place is on wheels. The number of interventions that are occurring at the same time is astronomical. And the political pressures that exist, and their political pressures do exist, because the politicians are responsible to the public, and they're spending money in areas that they want to see change immediately. And of course, that takes time. So I do worry about will these family care teams be implemented in such a manner that we're able to roster the population and deliver the scope of practice that we're hoping will happen. I worry about that, right? It's because you're changing a lot in that. The implementation of an integrated ground and air ambulance system, pressure, it's going to lead to change that people will want to resist, and it'll take time, and it'll cost lots of money. And then I worry about the capacity to change within the healthcare system, spending, $3 billion a year and wanting more money. our incapacity to be able to deal with what's coming down the track, which is the population is getting older. And we have to change the way we deliver healthcare fast. And if we don't deliver healthcare fast and develop a value for money approach to this, we're not only are we going to be in trouble, but we're not going to be able to deliver the services that we hope to deliver. So this whole piece of evaluating what we do, how well we do it, how much it costs, and making decisions to ensure that we're doing stuff that's valuable. And then the last thing I worry about, which is probably a personal thing really, but my feeling is that the key piece of any health delivery or social delivery is about compassion. And the environment seems to be driven by providers' feelings and that stuff. And have we lost the compassion to be able to work to the benefit of patients? And are we oriented towards not only hearing their voices, but acting that patients are our priority? So I'm not really being pessimistic, because I echo what's already been said by Cassie and Carla. There is a substantial degree of enthusiasm for change, but there is a substantial amount of implementation risk that we have to be able to keep on top of, and is going to be a major challenge.
Thanks for that, Pat. I'm going to go back to optimism. Acknowledging there's definitely risk, but I think the health coordinated 10-year plan, because change does take time. I think Newfoundland Labrador Health Services coming together as one back in April really created an environment where we can change and be transformative in our change. Not only do we have synergies and partnerships of the legacy organizations, because we all do great things in our legacy organizations, but now with the structures that have been put in place from government's perspective, but as well as in Newfoundland Labrador Health Services, and you can see the team sat around the table and the structures then that support us for transformation. I think the environment is really ripe for change, and I think the structures of the strategic health networks and really getting those evidence-informed practices to the front line. The front line is where the change is really going to happen, and having the patient's voice integrated in everything we do, including coming up with ideas in the networks, is really going to enable the change that's needed.
Tina. So I'm going to sort of have a balanced approach, I guess, too. So I do see the future is very bright. I do think that the environment is ready for change. And I think putting a structure in place that enables that will actually be very helpful. So for me, having worked for years in quality and patient safety, I actually feel that we're going to actually make a big difference. However, I do also echo Pat's comments around the rate of change and I know it's required, but just the impact that might have and the sustainability. So we need to make sure that we build in robust processes, that we also are living by our values, which includes compassion as we go forward, and recognize people are at the center and the heart of all this. And those people most definitely are about our patients that we serve. So I think, I would say the future's bright, with a few caveats around some of the things that we need to be mindful to as we go forward.
That was a bit of a roller coaster.
I'm the most optimistic man in the world, but I am realistic.
So I'm going to open it up for questions, and we got there we go. Start over here.
Thank you very much. Three questions. Whether we answer them now or not. For past curious if there is any thought with getting materials in the future. Us adults have our own kind of ways of doing it. In addition to urban learning.
One question at a time, sweet Jesus.
So for those online, the question is talking about whether Pat talks with other departments, or particularly with the Department of Education.
So clearly, based on the discussion about the social determinants of health, education is absolutely critical as its own social determinant, but it's also critical in terms of our capacity to deal with health literacy and people being informed well enough to be able to make informed choices about their healthcare. So I'll just take the first piece first, the education piece. There is a need for an education transformation agenda that it spans 4 pieces. It spans early childhood development. It spans better outcomes in school, from junior high school up to high school. It includes actions in the social determinants of health amongst children and the education of children about healthy living and the social determinants of health, etc., which includes drug taking and those things. And then also the 4th component to it is the youth and upskilling youth in such a way that they're able to get jobs and get income and reduce their poverty amongst those groups of people. So that piece is a major objective, I would say, for the Wellbeing NL agenda. The piece about health literacy, we did mention that the Cardiovascular and Stroke Institute are going to take a prevention agenda. Cancer have got a prevention agenda. And we all need to take it. Those of us who deal with patients are trusted. And we need to be able to get out into the community and speak to prevention, which is and healthy living. That I think that's kind of really important. But we're also hoping that we can. There's an all-party discussion now on a council for quality and performance for the province, and if that comes to fruition, it will have a responsibility for reporting to the public on health outcomes from the health and social system, and in effect, a responsibility for health literacy, I suppose. It has a responsibility for evaluating the health accord, which in effect is evaluating how we implement all those major things, like right across the gamut, all those major things and how they're changing or how they're not changing. It's got a responsibility for advocating for the health and it's not only advocating for the learning, health and social system, but it's actually an integral part of the learning, health and social system, because it's taking that information and going forward to try and inform the public and educate the public. And then the 4th element is about data and data governance, but not data management, but more a 3rd party that can examine how data is actually managed within the Provincial Health Authority and other places, and that is done according to appropriate ethical pieces. And the elephant in the room in this arena is artificial intelligence, which is changing everything, and it's going to have effects on not so much processes within the health system, which I'm not worried about, like it's business parts of it. I don't worry about that. But it's the other stuff, right? The measurement of practice, the influence of people, how we evaluate things, how algorithms work in dealing with, various groups in the population. It's really complicated, and nobody's on top of it. And that piece, and I'm thinking that piece as well is going to be a very relevant part for this council.
So I'm just mindful of time, so I'm going to move on to perhaps ask questions.
Somebody else can answer the next question.
Tina, I'm curious about the strategic clinical networks. Are you looking at a bottom-to-top approach or government directed, more of a consultative to direct priorities? And maybe at lunch, I'm curious. Sure, SCN failed, some has succeeded, and further looking at deconstructing. So just curious about thoughts from you.
Absolutely. So strategic health networks are really, it will include bottom, will include frontline, will include grassroots initiatives. We'll also bring together some of the priorities that have already been set from a strategic priorities perspective. So we'll really be in combination of both perspectives. I'm actually in conversations with Alberta and taking some of those lessons learned in terms of the way we construct our networks. So we'll be happy to chat, bring them further. Piece for Helen.
Information is great to hear it all. Very impressed, or I was very impressed this morning with the support network and how involved patients in research, and how that is. really interested in all the levels because I know in healthcare delivery, so we work in healthcare, pediatrics. And in healthcare delivery, we involve patients as advisory council. I don't think we involve them at the levels that they can be involved with. And so I'm interested in to inform healthcare delivery. You know, I don't know if there's any models on that or.
So I'll just, for people online, the question is basically asking about patient involvement in decision-making and policy-making as we move forward.
That's a great question, and there's a number of models, and you're right, we do have, within the health system, we have created patient advisory councils, as well as the strategic health networks that Tina spoke about. There will actually be patient partners, advisors on those strategic health networks. And as we build out our quality structures, we also, both at the provincial program and in the zonal programs, we will be involving patients. And so part of that is really to have them as part of the team, as an equal member of the team, to identify the problems, to identify the solutions, and actually to be involved with the implementation and the evaluation of the same. So that's absolutely our goal, is to be embedding patients in all of these processes.
Okay, so I'm just going to move to some, so you can perhaps approach these people after. So we got a few questions online. So you want to?
Yeah, so this question is related to access to technology across the province. As you know, there's many areas of the province where cell phone coverage, internet access is not always great. So one of our audience, online audience participants wanted to know if you could comment on how that might impact certain services offered, such as remote patient monitoring. We're looking at post-surgery things like that.
This is Cassie. I think it's a legitimate question. There's no doubt about it. I think we've all lived the misery of trying to maintain connectivity as we drive through different parts of the province and travel around. And certainly know that there are many communities that do have barriers when it comes to connectivity. I wish I actually knew the exact stats, but I apologize that I don't. What I would say is that we have it top of mind, and that we have, I think, to the point about the partnerships between health and education, we have partnerships that we are leveraging and building, expanding, internal to NL Health Services. For example, the digital health component of NL Health Services that have been pointed directly at this difficulty, the connectivity difficulty where it exists, as well as our partnerships at the government level, you know, with municipalities and infrastructure. And, you know, there's been a lot of attention paid to this at the national level as well. And we've certainly been supported to the best of my knowledge. Again, I wish I could quote specifics on this, but I can't. In general, I'm certainly aware that there's been quite a bit of support to solve some of these connectivity issues. So I would expect that in the coming, you know, months and years, we're going to see improvements in these areas, because these are solvable problems. You know, the technology exists out there. Unfortunately, it never moves as fast as we'd like it to, but I would have confidence that this is something that, you know, NL Health Services and our government and, you know, our structures here in the province have top of mind.
So the stats say that the broadband connectivity in Canada is 94%. And broadband connectivity in Newfoundland and Labrador is 93%. But I actually don't entirely believe that. Because, you know, our experiences are that we have difficulty with connectivity when we're dealing with places in Labrador, etc. I'd add that the federal government has committed hundreds of millions of dollars to getting more broadband connectivity. And they've also made a policy decision that if you can't get connectivity, they'll provide satellite connectivity. So I do think it'll get better.
And if I can add, I think in the interim, you know, as we're working through some of these, you know, innovative solutions, we are working with our partners. Library services, for example, across province have been leveraged to enable some of that virtual connectivity.
I'm looking for you for, am I getting close?
Yeah, I think.
Okay, so we're gonna have to wrap it up because we're about 10 minutes over time. So I want to thank our distinguished town for.